Hello, my name is Naveen Kumar, and I'm a gastroenterology fellow at the Brigham and Women's Hospital and research fellow at Harvard Medical School. Today, I'm joined by my research mentor, Dr. John Saltzman, who is the Director of Endoscopy at the Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. We will be discussing our upcoming study published in GIE entitled Timing of Upper Endoscopy Influences Outcomes in Acute Nonvariceal Upper GI Bleeding. Dr. Saltzman, according to current guidelines, when should patients with acute nonvariceal upper GI bleeding undergo upper endoscopy?
The current guidelines suggest that you should do an upper endoscopy within 24 hours of presentations in patients who present with nonvariceal upper GI bleeding. So that's where we are currently.
Now, the question often arises, should this patient go for upper endoscopy sooner than the 24-hour guideline?
And that is the question. In clinical practice, we often get called that a patient's admitted and can you come and scope them now? And the question is, should we scope them now? Is that the best thing for the patient? It's not clear whether we should be scoping them early or within the 24 hours. And this has been a controversial subject within endoscopy.
Has there been any research in this area, particularly for those patients who have higher risk bleeding based on bleeding prognostic scores?
Well, there's been general research that's shown the earlier you do endoscopy, the more things you find and the more therapy you do. But it hasn't shown in general that there are patient-level benefits, meaning rebleeding, surgery, mortality benefits. And then the research has gone to using risk prognostic scores to see, can you separate patients to high risk and low risk? And if you can, is there a patient population, assumingly the high risk, that would benefit from an earlier endoscopy? There is one study that's looked at this retrospectively. It was published by Lim. It's from Singapore. And evaluated, I think, 934 patients. And they separated patients into high-risk patients, which was a Glasgow-Blatchford score of more than 12 or more, or a lower risk population of less than 12, and they looked what happened in terms of timing and outcomes. And they found that in low-risk patients, it did not matter about timing of endoscopy, but in high-risk patients, those who had endoscopy within 13 hours had no mortality, and those who had a endoscopy longer than 13 hours had a 44% mortality. So this suggests that perhaps we can identify a high-risk group who may benefit from an early endoscopy.
Very interesting. So now in our study of 361 patients who with acute nonvariceal upper GI bleeding, we used a composite outcome that included inpatient death, inpatient rebleeding, need for endoscopic reintervention, surgical intervention, and/or interventional radiologic intervention. What was the rationale behind choosing these individual outcomes as part of the composite outcome?
Yeah, so that's a good question. There have been different studies that have had different endpoints, and you have to look very carefully at these endpoints. We chose a composite endpoint that I think are clinically meaningful endpoints. Obviously, mortality or death is a very hard endpoint, but also rebleeding, interventions, endoscopic reinterventions, or surgery, IR, are very important interventions. We did not include other endpoints such as endoscopic therapy, blood transfusions, ICU stays, because I didn't think that this would actually clinically matter. These are more process measures rather than true clinical outcomes for patients.
Dr. Saltzman, you nicely described the current literature that exists for timing of endoscopy, and particularly patients with higher risk bleeding potentially benefiting from more urgent endoscopy based on that Lim study. In our study, how did we classify a risk?
Well, we did the same thing. We just said, here's where the literature is. Let's do the same study in a U.S. population and see, do we get the same results or are there different results? So we basically divided our patients up into a Blatchford of 12 or more, or those who have less than 12, and then looked at timing of endoscopy and said, does it matter if you have an early endoscopy by Blatchford score within the low-risk group or the high-risk group?
In this study, 10% of the patients experienced the composite outcome with 2% dying. How does that compare to the current existing literature on mortality in acute nonvariceal upper GI bleeding?
So the current literature does vary a little bit by location and how the study is designed, but the 2% mortality is a very interesting figure in that it's widely been quoted that the mortality in upper GI bleeding is 5 to 14%. There have been two more recent studies, one done by Lauren Lane and one by our group, that show the mortality in the United States is closer to 2 to 3% as an inpatient. So it was exactly what I expected, actually, for our inpatient mortality. The other outcomes that ended up being about 10% are about what the literature would support as well.
In this study, we defined the time threshold for urgent versus non-urgent endoscopy at 12 hours. And we notably found that patients who underwent urgent endoscopy actually had a greater than 5-fold risk of experiencing a composite outcome as compared to those who had non-urgent endoscopy. Can you explain some possible reasons for this finding?
Yeah, so this is really intriguing that, patients who underwent early endoscopy, you come in and do it quickly, actually did worse. And there are a number of possible explanations. It's possible that patients do worse because they're under-resuscitated, that we don't have those 2 IVs in and the fluid going, and that when we sedate them, that they become hypotensive or they aspirate and have other untoward outcomes. So that's one possibility. Another possibility is if you rush in and do this, you may be doing endoscopy at off hours, you may not have the usual backups or supports, your performance may not be as good, and if you precipitate bleeding, and if it's 2 in the morning, you may not have your surgeon or interventional radiologist available to help with that patient. So there are a number of reasons why patients could do worse. On the other hand, it's possible that we just selected patients who were sicker, and our study, is confounded by we may have done earlier endoscopy in sicker patients. Although when we try to get at this by looking at the Blatchfords of those who had early endoscopy versus late endoscopy, they were identical. And when we looked at the rates of transfusions, they were also identical. So it's not obviously sicker.
Very interesting. So one of the most, I think, compelling results of the study was when we actually looked at the subgroup analysis of lower risk and high risk. And we found that patients who had lower risk bleeding prognostic scores actually did worse with more urgent endoscopy compared to non-urgent endoscopy. But then when we looked at the high risk patients, timing endoscopy was not a significant predictor.
Yeah, so this is exactly opposite the results of the earlier study that I quoted. So the high-risk patients, it didn't matter at the time of their endoscopy. And probably that's because we know they're high risk. We recognize that. They're managed in ICUs. They're given good resuscitations. They're managed very aggressively. Whereas the low-risk patients are not truly low risk. When we think of low risk with Blatchfords, we think of Blatchfords of 0, maybe 1 or 2. These had a mean Blatchford of 7 to 8. These are sort of intermediate risk bleeders, and some of them didn't do well with early endoscopy. And I think, again, this is probably the under-resuscitation and thinking they're low risk, maybe not giving them aggressive care, medical care, IV PPIs, resuscitation up front, doing early endoscopy, then getting into trouble with these patients.
Lastly, will the results of this study change your clinical practice, and what do you want to see done in the area of research for this field?
In terms of clinical practice, this is a very important study in that we have to decide, do we come in and scope patients urgently? And intuitively, the only patients that will benefit from an early endoscopy are those who are actively bleeding at the time of the endoscopy that we stop. Any other stigmata doesn't need to be done urgently. And we can't tell that right now, and that we don't have the scores to tell that for sure. In general, this will change practice, in my opinion, and that we should focus in on the medical care of these patients, the resuscitation of these patients, the IV PPIs, and then we should do endoscopy at a time where we have our resources available so we provide effective care. So I think that we're not going to be rushing in as much to do this. We're going to be making sure we're doing all the general medical things with the caveat that patients who we think are ongoing active bleeding in our clinical judgment, we should still do an early endoscopy, in my opinion. Now, where the research has to go is, of course, prospective randomized controlled trials to look at this question, look at bleeders, stratify them, and then change the timing of endoscopy and see if there truly is any difference in outcomes. But, I think that this is compelling retrospective data showing actually a difference with worsening outcomes with an early endoscopy in this low-risk group.
Thank you for watching our interview for the GIE Author Series on our recently published study in GIE entitled Timing of Endoscopy Influences Outcomes in Patients with Acute Nonvariceal Upper GI Bleeding. We hope you enjoyed the interview and thank GIE again for this opportunity.